Clinical chemistry, gastrointestinal function. The gastrointestinal tract is an 8-meter tube that begins at the mouth and ends with the anus. Several organs are identified here. So we go from the oral cavity into the pharynx, which is the throat, the esophagus, into the stomach, and then we have the small intestine, which has the duodenum, jejunum, and ileum. And then we enter into the cecum, which is the initial part of the large intestine. And from there, we have the ascending, transverse, descending, sigmoid, colon, rectum, and anus. There are 3 accessory organs that aid in the digestive process. The pancreas, which is over here on the left-hand side underneath the stomach. And then we have the large organ, the liver, on the upper right side here. And underneath the liver is the gallbladder. There are 3 phases of digestion: the cephalic, gastric, and intestinal phases. The cephalic phase is when you first smell or taste food, you start to get watery mouth, and that's the neurogenic and vagal phase of digestion. Once food is in the mouth, it stimulates the swallowing reflex, and then food will be swallowed down into the stomach, and those peristaltic contractions through the esophagus occur to get the food into the stomach. Once food enters the stomach, we're in the gastric phase, and this is initiated by the distension of the stomach because food is pushing on the lining of the stomach. It stimulates the release of hydrochloric acid and direct stimulation of parietal cells by the vagus nerve. So the vagus nerve plays a major role here in causing the release of hydrochloric acid from those parietal cells. And then it also stimulates gastrin production by the neutralization of gastric hydrochloric acid by the food entering the pyloric zone of the stomach. Gastrin stimulates antral motility, secretion of pepsinogens, pancreatic fluid rich in enzymes, the release of GI hormones, secretin, insulin, acetylcholine, somatostatin, pancreatic polypeptide, and food is mixed with those gastric secretions and is turned into chyme. Following the gastric phase, we have the intestinal phase, and this is initiated when weakly acidic digestive products enter the duodenum. Pancreatic juices enter the duodenum through the ampulla of Vater and sphincter of Oddi. Carbohydrates are digested by amylases and saccharinases. Protein is digested by pancreatic and intestinal enzymes. Dietary fat is emulsified by bile first, and then it's hydrolyzed by lipase. Digestive process ends with the formation of feces in the large intestine. This is a table that shows the hormonal regulation of the intestinal phase. You should take some time to review each one of these hormones and their functions. This is a visualization of where each one of these hormones is active. So you can take a look at this. Gastrin starts its activity in the stomach, and then duodenum and jejunum, ending in the jejunum. CCK is the duodenum, jejunum, and ileum, and you can kind of look at each one of these hormones. Absorption. Absorption of the major macromolecules occurs in the small intestine. Carbohydrates are absorbed by active transport into the bloodstream. Proteins are absorbed as amino acids, dipeptides by special absorptive mechanisms. And then digested lipids enter the intestine as a micelle. So the fatty acid monoglycerides diffuse into the intestinal epithelial cells, and fat-soluble vitamins are absorbed with lipids throughout the intestine. It's important to make a note that absorption can happen in other locations in the digestive tract. It's just we're talking about the macromolecules, the major nutrients of the diet. The majority of the absorption happens in the small intestine. If you think about when you take Tylenol, Tylenol takes about 15 minutes before you start to feel the effects of Tylenol. That medication can be absorbed through any absorptive surface of the digestive tract. So we can start the absorption through the tissues inside the mouth, through the esophagus, through the stomach, and so forth. If we were to have to wait until it got to the small intestine before it was absorbed, we'd be looking at 7 hours before we started to feel the effects of the medication. So there are other surfaces in the digestive tract that can be absorptive surfaces. It's just the majority of our macronutrients are going to be absorbed through the small intestine. Gastric diseases, so starting with ulcers. Ulcers result from the loss of normal internal or external surface of the body. In the GI tract, it's most commonly found in the stomach or in the duodenum. Most often caused by excess acid, so peptic ulcers. There's chronic duodenal ulcers and there's chronic benign gastric ulcers. Causes are multifactorial, but there are some risk factors, including the blood group, so group O, local, so decreased mucosal prostaglandins and damage to the mucosal lining locally, and an infection with Helicobacter pylori. Definite diagnosis is based on morphological diagnosis. Identification of H. pylori infection in patients with dyspepsia. Serological tests can detect H. pylori. We have the H. pylori antigen detection in feces. We can do a gastric biopsy and look for the presence of H. pylori on the surface of the intestinal mucosa. And we also have the urease or urea breath test. So we would have the patient swallow radio-labeled carbon, so C13 or C14, that's incorporated into urea. H. pylori can consume urea, so when it does, it releases this radioactive isotope of carbon, and then the patient would breathe out, and if they start breathing out this radioactive carbon, then we know that H. pylori is likely present in the stomach. It's highly sensitive and specific in 99% in untreated patients. Zollinger-Ellison Syndrome is extreme form of peptic ulcer disease. It's characterized by recurrent peptic ulcerization, often accompanied by diarrhea. Most common causes are gastrinoma, a gastrin-secreting tumor of the pancreas, or antral G-cell hyperplasia of the stomach. It's characterized by high basal acid output, BAO, and maximal acid output, MAO. BAO to MAO is greater than 60% pathognomonic for the disease. Normal is 5 to 20%. So ZE syndrome can be associated with other hyperplasias, hyperparathyroidism, multiple endocrine neoplasial syndrome type 1. It's a condition characterized by multiple endocrine hyperplasias, parathyroid, pancreatic islets, pituitary gland, adrenal, ovarian, thyroid, VI-poma. 25% of all gastrinomas are associated with the syndrome. Due to the mutation of a tumor suppressor gene, and it's an autosomal dominant inheritance, and there's also sporadic forms that exist. Characterization of gastrin levels. So fasting gastrin levels with ZE syndrome are 2 to 2,000 times the normal range. Serum gastrin levels greater than 1,000 nanograms per liter with gastric acid hypersecretion is diagnostic of a gastroma or ZE syndrome. There is a secretion method. Its significant overlap can occur with patients with common peptic ulcers. Increased gastrin interferes with salt water absorption, which causes diarrhea. Increased gastric acid in the duodenum interferes with fat absorption, which causes steatorrhea. Steatorrhea is excessive fat in the feces, and we're talking about greater than 7 grams per D. Gastrin Analysis immunoassay reported in G17 equivalents. Gastrin form G34 is most common in patients with a gastroma. Gastrin form G17 is used as a calibrator in the assay. Sampling considerations, it's unstable in serum even when refrigerated. You want to keep it -70 for long-term storage. Centrifuge promptly, remove from clot. Divide into 2 aliquots and freeze until assay is performed. Assay immediately upon thawing, do not refreeze. Basal acid output and maximal acid output. BAO is measured as a 1-hour test after an overnight fast, followed by a 1-hour simulation test. ZE syndrome shows extreme acidity. Gastric peptic ulcer is associated with normal secretory volume and acid output. Duodenal peptic ulcer is increased secretory volume and acid output. Pernicious anemia is anacidity. And then there's stimulation tests for secretin and pentagastrin. Interpretation of increased gastrin levels. There's appropriate or inappropriate. Appropriate, acid secretion is low and antral G cells function normally. Gastrin appropriately elevated as G cells increase in number or hyperplasia. Atrophic gastritis, pernicious anemia, and renal failure are indicated. Inappropriate if the acid secretion is normal, fundic mucosal normal function, and gastrin is elevated. That indicates a gastrinoma, isolated retained antrum after gastric surgery, primary gastrin cell hyperfunction. Diarrhea is an abnormal increase in one or more stool characteristics, daily weight, liquidity, or frequency. It results from solute malabsorption, motility disturbance, or secretion of fluid into the intestine. High amounts of poorly absorbed osmotically active solutes, intestinal ion secretion, increased epithelial permeability due to obstruction or inflammatory or infectious disorders of the bowel, or replacement of absorptive epithelium by corrupt epithelium or crypt epithelium. Classification of diarrhea. Osmotic diarrhea is caused by poorly absorbed osmotically active solutes. Carbohydrates, divalent cations. Secretory diarrhea is the inhibition of ions absorbed or stimulation of ion secretion. Characteristics: stool osmolality is accounted for by normal ionic constituents. The condition persists after fasting. Pus, blood, excess fat are not present. Enterotoxins or bacterial exotoxins: cholera, E. coli, Salmonella typhimurium, Shigella dysenteriae, Staphylococcus aureus. Tumor production of cetragogues, alteration of electrolyte fluid movement, bile acids, over-the-counter laxatives. Inflammatory bowel disease or paroxytic infections. Decreased solute absorption due to loss of mucosal transport. Celiac disease is altered mucosal morphology. Monosaccharide malabsorption, isolated transport defects. Verner-Morrison Syndrome is a watery diarrhea syndrome. Watery diarrhea, hypokalemia, hypo means less, K is the element symbol for potassium, so we're talking about lower potassium, and hypochlorhydria or achlorhydria, sometimes seen as part of Men syndrome, usually due to pancreatic non-B cell tumor secreting VIP. VIP causes vasodilation with facial flushing, increased intestinal blood flow, induces watery diarrhea, and inhibits gastrin secretion. Diagnosis is by eliminating other causes of diarrhea, usually with hypo or achlorhydria. Diagnosis is confirmed by elevated levels of VIP. Other disorders of the large intestine: the blind loop syndrome. Regional outpouching in the large intestine is caused by inflammatory or anatomical disorders. Material becomes trapped, allowing bacterial overgrowth that leads to excessive breakdown of bile conjugates. Deconjugated material cannot be reabsorbed, and it can lead to diarrhea. Here we use the bile acid breath test, so 14 carbon 14 labeled glycinocolate administered orally, and then the carbon dioxide would be trapped in alkaline solution and detected radioactively. There's also idiopathic inflammatory disorders. It's present with abdominal pain, diarrhea, malabsorption, ulcerative colitis, and Crohn's disease. Ulcerative colitis affects the large intestine, and Crohn's disease affects the small intestine. Evidence of autoimmunity and familial predisposition is associated with both. Malabsorption versus maldigestion. Malabsorption, the GI tract is impaired and it's unable to absorb a variety of nutrients. Maldigestion means that there's an impairment of the digestive process that leads to inadequate absorption of nutrients. So malabsorption, the actual digestive tract itself can't absorb the nutrients. Maldigestion means that the nutrients can't be broken down small enough to be absorbed. It's most commonly caused by pancreatic insufficiency, also with inadequate pancreatic enzyme activation, associated with achlorhydria or excessive acid production, inadequate bile production or secretion, typically leads to fat malabsorption and steatorrhea. Malabsorption syndromes result from interference with digestion or absorption of food. It's characterized clinically by loose stools, typically containing fat or steatorrhea, loss of weight or failure to gain weight in children. And then there's secondary deficiencies in fat-soluble vitamins, bone disease, prolonged clotting times, poor night vision, neuropathy. It's caused by pancreatic insufficiency, which is most common, achlorhydria, leading to inadequate pancreatic enzyme activation or inadequate bile production or secretion. Steatorrhea. Stools are characteristically pale, bulky, and greasy with a repugnant odor. It's important to distinguish clinically stools from those due to other causes of diarrhea, the amount of fat present, and the specific cause. So causes would be ZE syndrome, increased duodenal acid, abnormal bile output, pancreatic insufficiency, intestinal mucosal impairment, or diseases of the large intestine causes an interruption in bile, salt, and enterohepatic circulation. Fecal fat determination, so fat screening, the evaluation of weight and appearance of stools. Pale, frothy appearance is diagnostic of excessive fat. Stain specimen with fat-specific stain. Microscopic examination for the presence, size, and number of fat droplets. 10 times as many fat droplets seen with steatorrhea. Diameter of droplets correlates with total fecal lipids. Perform a Steatocrit, which is the percentage of fat quantified or quantitated in a random sample. The sample is homogenized with sand and 2 volumes of water. Aliquot of mixture is centrifuged in a microhematocrit tube. Patients with steatorrhea have 3 layers. The lower layer is a non-fatty fecal solids, intermediate layer is a liquid layer, and the upper fatty layer is expressed as a percent of total fecal solids. In the absence of steatorrhea, upper reference level is 2.1%, so anything higher would be steatorrhea. The quantitative estimation of fecal fat. For definitive diagnosis of steatorrhea, it's performed on a 72-hour collection. For 2 days prior, during the collection, the patient must include 100 grams medium-chain triglycerides in their diet. Weigh the sample, perform analysis on a well-mixed aliquot of 3-day collection, quantitated by near-infrared reflectance analysis, which measures the radiation scattered by the surface of the spot of fecal sample. Variations in wavelength allow the determination of dry weight, total nitrogen, total fat, and hydrolyzed fat. Separate determination of total fat and hydrolyzed fat allows the indication of the origin of steatorrhea. Other malabsorption disorders, celiac disease. Celiac disease is due to an immunologic response against wheat gluten. It's characterized by antibodies to gluten and enzyme, tissue transglutaminase. Symptoms include progressive weight loss, diarrhea, flatulence, and abdominal distension. Stools may be bulky, pale, foul-smelling, and floating. Osteomalacia and osteoporosis may develop. The disease may be subtle. It may manifest as anemia, iron deficiency, folate, vitamin B12 deficiency, and definitive diagnosis is made by intestinal biopsy. Ulcerative colitis is a chronic inflammatory disorder of unknown etiology, so we don't know what causes it. Most often affects the mucosa of the rectum and the left colon. It's characterized by intermittent attacks of severe diarrhea associated with rectal bleeding lasting for several weeks. Leads to anemia, water, and electrolyte imbalance. Toxic megacolon results when pathology extends into the muscular wall of the colon. Leads to shock, fluid, and electrolyte depletion. Further leads to renal failure and cardiac arrhythmias. Regional enteritis, Crohn's disease, is chronic inflammation of the intestine. Again, the cause is unknown. The distal ileum and the colon are most often affected. The entire intestinal wall is affected. Progresses to ulceration, fibrosis with contraction and obstruction, fistula formation between the loops of the gut or the gut and other organs. Complications, malignant intestinal neoplasms or intestinal cancer, arthritis, abnormal liver function, renal involvement, increased risk of stone formation. And then you have generalized malabsorption. The diagnosis of malabsorption, there's a screening approach, so you look for clinical signs and symptoms in at-risk populations. Laboratory screening is not sensitive. We look at serum albumin, calcium, vitamin B12, peripheral smear, analyzing for macrocytosis, and iron deficiency anemia. Then there's the lactose tolerance test and D-Xylose absorption test. The D-Xylose absorption test absorbed passively in the small intestine, independent of pancreatic enzymes. The amount recovered from the blood or urine within a specified time interval is used to evaluate mucosal absorptive capacity. It's a reflection of integrity of the surface area of the small intestine. So we would have the patient consume D-Xylose, and then we take blood samples and urine samples to see how much actually made it into the blood or in the urine. Low absorption is observed with intestinal malabsorption, especially in the jejunum. Celiac disease, tropical sprue, Crohn's disease, and blind loop syndrome. It's essentially normal in malabsorption due to pancreatic insufficiency. And then colon cancer. Malignancies of the colon or rectum account for over half of cancers of the GI tract. Screening is most effective at curing the disorder. Occult blood. Patients with colon cancer have small amounts of hemoglobin in their stool, so greater than 2 mg per gram of stool. There's a Guyac procedure. And dietary interferences, iron and peroxidases in red meat and various plants. Withhold red meat for several days prior to the procedure. Allow samples to stand for 2 to 3 days. Rehydration of dry samples prior to testing reduces false negatives but may increase false positives.